This video was produced for school.com/keto for cancer. Clinical Research Framework Proposal for Ketogenic Metabolic Therapy in Glioblastoma. Part 2. Starting the ketogenic metabolic therapy. Medications for blood glucose control. Implementation of DON to inhibit glutamine. Other compounds and supplements. Figures and tables. Initiate dietary ketogenic metabolic therapy. GKI-adjusted ketogenic diet, calorie-restricted ketogenic diet, and fasting can be administered in a neoadjuvant phase, in the peri-diagnostic period, uninterrupted, or resumed within 24 to 72 hours of surgical debulking, depending on the patient's condition. Mechanistically, these strategies have been studied to improve wound healing and reduce inflammatory markers, alleviate pain, and stimulate anti-tumor immunity, thus inducing a favorable physiological environment for post-surgical recovery. Long-term adherence should be stratified according to cumulative biomarker ranges, such as real-time tracking of GKI, which can be predefined as primary or surrogate endpoints. If ketogenic metabolic therapy has been initiated prior to surgery during a watchful waiting period, patients with adequate body weight and good functional status may accelerate ketogenic adaptation through water-only fasting, or fasting-mimicking diets, FMDs. However, adjusting to an isocaloric ketogenic diet or a calorie-restricted ketogenic diet for 1 to 3 weeks before undergoing zero-calorie or partial fasting enables a more gradual metabolic transition. A well-formulated ketogenic diet should proactively avoid common side effects, such as electrolyte imbalances or undesired lean body mass loss, to minimize negative impacts on quality of life. Initial weight loss during the transition to nutritional ketosis and fasting is mostly due to increased diuresis, water loss, and fat loss, not lean body mass loss. Adequate hydration and electrolyte supplementation, e.g. sodium, chloride, magnesium and potassium, is recommended for both ketogenic diets and fasting. In clinical trials, successful implementation of ketogenic diets is often accompanied by a reduction or discontinuation of medication, particularly for chronic diseases associated with insulin resistance, such as type 2 diabetes, dyslipidemia, NAFLD and hypertension. Based on changes in the metabolome, water-only fasting for periods over 72 hours is likely required to fully transition into the fasted state in humans, although more research is needed to determine the appropriate timing for anti-neoplastic effects. Medically supervised water-only fasting for over 60 days has been shown safe and effective in obesity management, and fasting mimicking protocols for up to 21 days have been implemented in large cohorts with normal baseline weight. While sufficient body fat stores could allow for therapeutic fasting beyond 1 to 3 weeks in select patients, feasibility studies focused mostly on 5 to 7 days in GBM, as well as short-term and fasting mimicking protocols in other malignancies. After the fast, the attending dietitian should instruct a slow and methodical refeeding, while still adhering to GKI targets, to prevent overfeeding, electrolyte imbalances, or reactive hyperglycemia. If fasting is contraindicated due to risk of cachexia or pre-existing health conditions, an isocaloric GKI-adjusted ketogenic diet can be initiated instead. It is important to review sodium restriction, as low-sodium diets have been shown to deplete magnesium and increase insulin resistance, thus promoting hyperglycemia. Similar to water-only fasting, a strict ketogenic diet is expected to induce mild diuretic effects and improve glycemic control. Accordingly, it is recommended to reevaluate existing prescriptions, e.g. antihypertensives, antidiabetics, and replenish electrolyte levels, especially prior to acute dietary changes. Asymptomatic hyperuricemia may also develop in a small subset of patients and should be monitored, resolving spontaneously in most cases. The initial weight loss from adipose tissue is expected to continue slowly and controllably during a calorie-restricted ketogenic diet. It is important to remember that gradual fat utilization associated with calorie-restricted ketogenic diet and fasting is therapeutic, whereas lean body mass loss associated with cachexia is pathogenic. Isocaloric feeding to maintain muscle mass should be favored over chronic calorie restriction in individuals at borderline low weight, e.g. BMI less than 18, or as determined by the dietitian. Participants that cannot comply with the diet, e.g. impaired swallowing function, could receive nutrients in optimal balance via enteral feeding, as demonstrated in pediatric and adult patients with epilepsy, or, if enteral feeds are not possible, via parenteral ketogenic nutrition. Radiation therapy. In addition to neurosurgery, radiotherapy of growing sophistication has remained the cornerstone of GBM therapy. The current standard of care recommends postoperative radiation with target volume delineation, for a total dose of 60 GY in 30 fractions. Temozolomide alone is typically only considered in elderly patients, especially if the tumor is MGMT methylated. Despite short-term cytotoxicity to cancer cells, ionizing radiation induces metabolic reprogramming in the tumor niche, negatively influences the phenotype of recurrence, and triggers secondary inflammatory responses in the peritumoral tissue, while also damaging normal brain parenchyma and blood vessels. Even targeted modalities can cause delayed adverse effects that are seldom factored in the risk-benefit analysis given the poor overall prognosis. Concerns have been raised about the potential off-target brain toxicity caused by conventional radiation protocols. Consequently, it will be important to design clinical trials comparing the potential synergistic benefit of radiation-induced cytotoxicity, chemosensitization, and immune modulation, with the residual adverse effects on surviving tumor cells and their microenvironment. To meet institutional review board requirements, radiotherapy could be conditionally and sequentially delayed for a clinically acceptable period based on interim response analysis or applied at low-dose regimens as a synergistic potentiation strategy. In other types of cancer, ketogenic diets and fasting have been proposed as feasible and potentially effective radiotherapy adjuncts, acting as radiosensitizers while mitigating adverse effects. It is worth reiterating that, in contemporary medical ethics, therapeutic decision-making is ultimately driven by the informed patient. Accordingly, brain-sparing modalities of radiation may be offered as auxiliary or salvage therapies if other approaches have failed or if they are actively requested by the participant. Drug treatments. It is our view that any drug therapy will be most effective once the patient reaches a stable therapeutic GKI zone. For example, 2.0 or below, ideally 1.0 or below, with special attention to absolute glucose levels and insulin signaling, which should be at their physiological minimum. A combination of nutritionally balanced ketogenic diets, calorie restriction, and fasting will promote therapeutic ketosis, after which drug therapies can be initiated. As corticosteroids decrease immune function and increase glycemia, independently associated with poor GBM survival, they should be used only when unavoidable, at the lowest dosage for the shortest possible time. It is important to recognize that intensive standard of care therapy, particularly high-dose corticosteroids and radiation, could lead to erratic glycemia or low ketonemia despite strict diet adherence. Based on previous reports, more intensive dietary changes, such as cyclical water fasting, longer than 3 to 5 days, and Paleolithic ketogenic diets, meaning 0 grams carbohydrates per day, with a narrow feeding window, e.g. intermittent fasting with 1 meal per day, may be required to reach a stable GKI during concomitant steroid and radiation therapy. After transitioning to a sustained GKI-adjusted ketogenic diet or a calorie-restricted ketogenic diet, pharmacological targeting of glycolysis and glutaminolysis should be implemented gradually, ensuring any off-target fermentation inhibition in normal cells is buffered via ketone body metabolism. Baseline ketogenic adaptation is a sine qua non condition for the safe targeting of fermentation fuels. This is not required for modulating other cancer-associated pathways, such as redox balance, immune response, or autophagy, but is recommended for its synergistic anti-proliferative, anti-inflammatory and anti-angiogenic effects. While we provide general recommendations based on the Press Pulse therapeutic principle, a multitude of clinically approved drugs have been proposed as candidates for GBM therapy. Combinatory approaches, rather than single pathway targeting, may be necessary for optimal results. However, in efforts to isolate confounding variables and mitigate financial risk, only a small number of clinical trials have tested multi-drug additions to standard of care, seldom with dietary metabolic priming. The intellectual property landscape and lack of financial incentives to explore non-patentable combinatorial approaches is a significant challenge for the validation of promising preclinical observations. Regardless of the clinical context, monitoring of adverse events and dose modification schedules must be in place for any tested pharmacological agent. The timeline of drug administration is outlined in Figure 5 and can be structured as follows. A. Dietary ketogenic metabolic therapy, GKI-adjusted ketogenic diet or calorie-restricted ketogenic diet, and fasting, reduces the glycolytic dependency of normal tissues and stimulates compensatory ketone body metabolism. B. If the tumor is shown to be glycolytic, i.e. high 18-FFDG uptake, consider additional systemic targeting of substrate, such as renal glucose reabsorption or gluconeogenesis inhibitors, e.g. SGLT2 inhibitors, metformin. Direct inhibition of glycolysis should be administered only after reaching sustained therapeutic ketosis to improve safety and tolerability. Keto adaptation. C. We propose that concurrent targeting of glutaminolysis is essential to avoid therapy resistance. At this time, one of the anti-glutaminolytic drugs considered to work best as part of ketogenic metabolic therapy in preclinical models is the pan-glutaminase inhibitor 6-diazo-5-oxo-L-norlucine, DON. Any prospective compound that can safely and effectively target glutamine availability and/or utilization may elicit comparable effects, such as DON prodrugs or novel glutaminase inhibitors. D. After cancer cells have been rendered vulnerable by press pulse metabolic pressure, cancer-associated pathways and the tumor microenvironment can be targeted via synergistic drug combinations. Pharmacological targeting of glycolysis. Dietary ketogenic metabolic therapy shifts whole body physiology to an evolutionarily conserved metabolic state of nutrient scarcity that is inhospitable to tumor growth, but facing advanced disease will require multimodal and combinatorial strategies. Further improvements to GKI, substrate availability, and direct targeting of glycolysis can be implemented after ketogenic adaptation via drug repurposing or investigational compounds, depending on the clinical context. Metformin at standard antidiabetic dosing improves glycemic control via mild liver gluconeogenesis inhibition and increased insulin sensitivity. Cancer therapy with metformin is being evaluated in an expanding number of clinical trials due to its good safety profile, mostly as a synergistic addition to standard of care. Berberine, an over-the-counter alternative, exhibits similar effects on glycemic control. SGLT2 inhibitors, e.g. dapagliflozin, empagliflozin or canagliflozin, can be considered to further decrease GKI and insulin signaling. Dose adjustments and monitoring of ketoacidosis is required during ketogenic diets and fasting, especially in patients with a history of type 2 diabetes or who are prone to ketoacidosis. SGLT2 inhibitors experienced a recent resurgence as attractive combinations with PI3K inhibitors via suppression of the insulin feedback loop. However, greater synergy was observed with the ketogenic diet in certain preclinical models, even if future clinical adoption would be more demanding. Therefore, a dual combination of low-dose SGLT2 inhibitors and ketogenic diets warrants further research. In fact, the ketogenic diet is now being rebranded as insulin-suppressing, and trials with PI3K inhibitors are underway. MCTs and exogenous ketones can rapidly boost ketone levels and prevent hypoglycemic events during drug therapies, ketogenic diets or fasting, as well as mitigating central nervous system oxygen toxicity in adjuvant hyperbaric medicine. Pharmacological targeting of glutaminolysis. In the context of monotherapy inhibition of glycolysis, cancer cell viability could be rescued by the other primary fermentable fuel, glutamine. Even though intratumoral heterogeneity and clonal selection creates a potentially unlimited mutational and epigenetic landscape, the number of metabolic substrates able to sustain proliferation is unlikely to be unlimited in light of the universal mitochondrial defects and bioenergetic, anabolic dependencies found in GBM. Currently, novel glutamine antagonists and other metabolic inhibitors such as DON prodrugs, or CB839, are being tested as monotherapy additions to standard of care. Single pathway inhibition may not be optimal due to functional redundancy. Unless proven otherwise through metabolic stratification, we propose concurrent initial targeting of glucose and glutamine-driven fermentation after ketogenic adaptation, given that they are the most robustly consumed for energy, biomass, and redox homeostasis. DON is the prototypical drug for broad-acting glutaminolysis inhibition, targeting multiple isoforms of glutaminases and glutamine utilizing enzymes. DON is currently not FDA approved, but has an extensive history of clinical testing, a relatively good safety profile at moderate doses, and could be revisited as a research therapy in its original or prodrug forms. Continuous daily parenteral administration produced dose-limiting side effects in previous clinical trials, most notably, oral mucositis, nausea, vomiting, and myelosuppression. Premedication with antiemetics can be implemented prophylactically. Instead, congruent with the short half-life, 1.2 hours, low-dose intermittent administration would be preferable, as suggested by initial dose escalation studies. Thus, future research may consider parenteral or oral administration in the 0.2 to 1.1 mg per kilogram per day range, adjusted to individual tolerance. While DON prodrugs with improved oral bioavailability are being developed, the original compound demonstrated biological activity at oral doses up to 1.1 mg per kilogram per day for a duration of 2 or more weeks. DON has been administered orally as a single daily dose, without resting periods, continuous split doses every 4 to 6 hours, with a higher incidence of side effects such as oral mucositis, or as single or split doses given intermittently every 2 to 4 days, lowest incidence of side effects. Preclinical evidence from our group suggests that the calorie-restricted ketogenic diet may increase DON concentrations across the blood-brain barrier and reduce dosing requirements when administered on a per-need basis. Based on previous clinical testing, the recommended starting point would be a lower daily dose taken with a fatty meal vehicle in a single, e.g. 0.4 mg per kilogram once a day, or split schedule, e.g. 0.1 mg per kilogram every 6 hours, with a 1 to 3 day resting period upon side effects, increasing to 1.1 mg per kilogram, or higher, based on tolerance and pharmacokinetics. Single 1.2 to 2.5 mg per kilogram oral doses were necessary to reach serum peak concentrations comparable to 0.6 to 1.2 mg per kilogram intravenous infusion. Consequently, rather than oral administration, subcutaneous delivery starting in the 0.2 to 0.4 mg per kilogram range, twice or thrice weekly, may be preferable for improved bioavailability and convenience in outpatient care. Ideally, DON would be administered after confirming stable therapeutic ketosis as a synergistic potentiation strategy. It has been suggested that supplementing DON with adenine, 400 mg per day, or 4-amino-5-imidazole carboxamide, 800 mg per day. Gastric pH buffering, due to DON acid labile properties, and hypoxanthine and increased fiber intake, may reduce off-target damage to the oral and intestinal mucosa. Nevertheless, the mechanisms underlying these protective effects and their relevance on therapeutic efficacy will need to be confirmed in future studies. Sodium phenylbutyrate is a clinically approved orphan drug for urea cycle disorders and neurodegenerative diseases, with potential anti-tumor effects as a single agent, or coadjuvant with glutamine antagonism. Phenylbutyrate rapidly metabolizes to phenylacetate, conjugated with phenylacetyl-CoA and glutamine, acting as an ammonia scavenger and inducing durable plasma glutamine depletion. Clinical trials in solid tumors noted a sustained dose-dependent reduction in plasma glutamine with oral doses between 180 and 360 mg per kilogram per day, up to a maximally tolerated dose of 27 grams per day. Phenylbutyrate decreases systemic availability of glutamine, resulting in substrate competition. Thus, similar to PEG-glutaminase, phenylbutyrate-induced glutamine depletion may be explored to reduce dosing requirements of DON or other enzyme-level inhibitors of glutaminolysis. L-asparaginase, a first-line treatment for a variety of lymphoproliferative disorders, induces acute extracellular glutamine depletion through conversion to glutamate, a mechanism hypothesized to play a significant role in its anti-neoplastic benefits. L-asparaginase requires parenteral administration and is currently available in 3 formulations, including generic drugs. Clinical trials in solid malignancies have focused primarily on single addition to chemotherapy in pancreatic cancer, yielding only marginal improvements in survival. Consequently, it has been proposed that combinations with specific glutaminolysis inhibitors, such as DON, may further improve therapeutic efficacy. Repurposed drugs with potential inhibitory effects on the glutaminolytic pathway include aminoxyacetate, apomorphine, tamoxifen, raloxifene, sulfasalazine, and ceftriaxone. Over-the-counter nutraceuticals with direct or indirect effects include EGCG, xanthomycin and hesperidin, ursolic acid, caffeic acid, curcumin, apigenin, and berberine. Pharmacological targeting of the tumor microenvironment and cancer-associated pathways. The patient's internal macroenvironment, that is, whole body physiology and its exposome, also plays an undeniable but often forgotten role, especially if envisioning cancer as a competing ecological process between normal and malignant cells. For example, insulin resistance and the accompanying hyperinsulinemia have been correlated with poor prognosis and can substantially reduce the efficacy of certain therapeutic approaches, such as inhibition of the insulin, PI3K axis. GKI-adjusted ketogenic diets and fasting promote a wide-ranging normalization of the patient's physiological macroenvironment, as well as the local tumor microenvironment. We hypothesize that classical anti-neoplastics and targeted efforts would be enhanced if applied on a baseline of dietary ketogenic metabolic therapy with effective fermentation fuel targeting. Additional File 6 Table S3 summarizes clinically approved drugs and strategies that have been proposed to modulate the GBM microenvironment. We refer to additional reviews discussing novel compounds and off-label indications with preclinical evidence that may hold promise, but require further clinical testing. It is important to note that this list is based on pre-existing clinical use, drug repurposing, and may not involve the most potent or selective compounds in their respective category. Rather, the intent is to address health disparities and lower the financial burden of cancer treatments, promoting a democratization of cancer care and off-patent drug development through publicly funded research. Additional File 1 Appendix 3 provides further detail on an illustrative selection of repurposed drugs that have initiated pilot safety and feasibility studies in GBM. Over-the-counter dietary supplementation. As a general concept, lifestyle interventions and supplementation are intended to improve the adaptive capacity of the non-tumoral cell mass, the prevailing portion of the patient's ecology, which will compete with the tumor for bioenergetic and biosynthetic resources. This also improves the likelihood that targeting of glycolysis, glutaminolysis, and the tumor microenvironment will be better tolerated by normal cells, or that synergistic opportunities may arise. Additional File 7 Table S4 includes common over-the-counter nutraceuticals with emerging preclinical and clinical evidence for complementary cancer use. It is exceedingly unlikely that large randomized clinical trials will be performed for non-patentable natural products. It must be clearly stated that supplementation is not intended to resolve advanced cancer, and owing to its namesake, it should be viewed as supplementary. However, when implemented judiciously, it is also unlikely to interfere with most conventional anti-neoplastic drugs or ketogenic metabolic therapy, thus becoming a personal choice of the informed patient. Physical activity. Moderate daily physical exercise is encouraged and should be tailored to the age and fitness of the patient, including both resistance, strength training for muscle maintenance, as well as aerobic, high-intensity training for cardiometabolic health. As a core pillar of ketogenic metabolic therapy, physical activity is anti-cachexic, increases insulin sensitivity, and facilitates physiological glucose and glutamine clearance. Furthermore, low-intensity endurance exercises such as regularly spread-out walking, smaller doses but higher frequency, modulates osteocalcin and glucagon signaling, consequently lowering glucose availability and insulin secretion. Recording of metabolic parameters, such as GKI, should be contextualized, as fuel utilization and transient stress responses may influence measurements in the post-exercise window. In light of the beneficial effects of exercise on reducing cancer mortality and recurrence, as well as the inverse association between muscle mass and strength with all-cause mortality, patients should strive for a daily dose of physical activity that is sufficient to stimulate muscle protein synthesis, adjusted to their training experience and comorbidities. For example, as per current cancer guidelines, aim for at least 150 minutes per week of aerobic exercise, 2 or more days a week of resistance training, or more than 10, metabolic equivalent of task, hours per week of overall physical activity. Stress management. Facing a serious cancer diagnosis can be traumatic and emotionally distressful, impacting patients' mental health and psychosocial well-being. It is pivotal that patients receive appropriate mental health support that suits their preferences and beliefs, including multidisciplinary psycho-oncological care with clinical psychotherapy, sleep hygiene, breathing exercises, limbic system retraining, meditation or prayer, not least because a high level of personal motivation is required for KMT implementation. On a physiological level, stress management is important to stabilize the hypothalamus pituitary adrenal axis and sympathetic nervous system, maintaining adequate cortisol levels, immune function, and circadian rhythms. Evaluation of outcomes and therapy adjustments. To assess the effectiveness of ketogenic metabolic therapy, we recommend monitoring tumor response using non-invasive anatomical or combined metabolic imaging within the first 1 to 2 months, e.g. MRI with elective 18-FFDG PET at 8 weeks, and then every 2 to 4 months during active treatment, in line with standard guidelines. If the tumor is stable or shows signs of partial response, follow-up can be scheduled every 2 to 4 months for the next 2 to 3 years, and less frequently thereafter. It is important to create a schedule that would enable timely adjustments to the therapeutic plan. In extraneural cancers, previously positive tumor markers as well as validated liquid biopsies may assist in estimating tumor burden. Repeated surgical debulking can prevent bulk effect, especially in slow-growing tumors. Active monitoring and a GKI-adjusted ketogenic diet, a calorie-restricted ketogenic diet should be maintained, as long as there is evidence of persistent disease or risk of recurrence. Conclusions. Ethical considerations and future directions. One of the greatest challenges in GBM therapy is the inability of the current standard of care to eliminate all microscopic tumor infiltration and cancer stem cells. After the inevitable recurrence, patients are often confronted with salvage therapies of limited clinical utility. These grim prospects make it difficult for physicians to communicate prognosis and for patients to make realistic and informed decisions about their preferred treatment plan. For terminal, incurable cancers, it is a matter of interpretation of medical ethics as to whom should be the arbiter of therapeutic decisions, especially for interventions where the risk-benefit ratio is not fully established. This is an ethical consideration, not a scientific one, to be decided collectively at the societal and policy level. Nevertheless, from a patient advocacy perspective, advancing education about novel therapies at all the levels of the evidence-based pyramid is essential to facilitate shared decision-making. Going forward, a larger collection of clinical trials will be needed to standardize the implementation of GKI-adjusted dietary ketogenic metabolic therapy with concurrent fermentation fuel targeting. We wish to inspire patients to take a proactive and informed role in the management of their disease, physicians to make evidence-based decisions while still exercising clinical freedom, and researchers to join the quest for discovery of the many promising therapeutic avenues that are yet to come, by targeting the fundamental bioenergetic dependencies of cancer cells. A flexible and modular protocol has been presented to guide translational GBM research, based on the evidence that most of the defining hallmarks of cancer can be explained from a mitochondrial metabolic perspective. As predicted by evolutionary biology, cancer cells suffer from a distinctive lack of adaptive versatility due to both mitochondrial and genomic damage, as well as persistent anabolic demands. GBM cells, like most other cancers, are comparatively more dependent on fermentation fuel flux for energy and biosynthesis due to universal defects in mitochondrial number, structure, and function. Despite ample downstream mutational heterogeneity, metabolic reprogramming, and single-cell heterogeneity. Ketogenic metabolic therapy is conceptualized as a press pulse therapeutic strategy. This framework can be adjusted for any cancer subtype that is unable to proliferate under the relative restriction of both glycolysis and glutaminolysis, fermentation dependency, even when supplied with compensatory oxidative fuels. OX-phos insufficiency. Future research, stemming from collections of case reports and clinical trials, will offer unique insights into the optimal dosing, timing, and scheduling for maximally safe and effective fermentation fuel targeting, after physiological adaptation to therapeutic ketosis. Figure 1. Simplified diagram of normal and cancer cell metabolism, with special emphasis on ATP synthesis. SLP and OX-phos. All living cells must meet their ATP demands. Normal cells, including growth-regulated proliferating cells, generate the majority of ATP through the multi-step, ultrastructure-dependent process of OX-phos. Cancer cells exhibit abnormalities in mitochondrial structure, function and/or number, as well as increased biosynthetic and redox demands, leading to a comparatively reduced efficiency of OX-phos and compensatory upregulation of cytosolic and mitochondrial SLP, SLP meaning fermentation. Cell division can be constrained by biosynthesis in the excess, assuming sufficient ATP, but energy is limiting for survival under nutrient depletion. The goal of ketogenic metabolic therapy is to synergize with other therapies by targeting fermentation fuel availability in cancer cells, and upregulating OX-phos in normal cells, increasing metabolic stress and whole-body ecological competition. Figure 2. Illustrative diagram of blood glucose, beta-hydroxybutyrate, and GKI during different phases of dietary ketogenic metabolic therapy. Note that the suggested glucose and ketone levels are representative of inter-individual and intra-individual variability, not prescriptive. In this example, after initiating a GKI-adjusted ketogenic diet, glycemia is maintained below 5 millimolar and ketosis above 1 to 2 millimolar. The proposed therapeutic zone has been achieved once glucose levels are less than two-fold ketone levels, GKI equal or below 2, and optimal when glucose levels are equal or lower than ketone levels, GKI equal or below 1. Absolute glucose levels should be at their physiological minimum. Dietary, stress, or therapy-induced excursions, e.g. corticosteroids, should be minimized. Exercise-induced gluconeogenesis is expected and offset via skeletal muscle demand. As a long-term therapeutic strategy, dietary ketogenic metabolic therapy may continue as long as there is evidence of persistent disease or risk of recurrence. Real-time GKI tracking is recommended in research settings to avoid ambiguity regarding biological outcomes. Figure 3. Overview of ketogenic metabolic therapy implementation in high-grade glioma research, including both dietary ketogenic metabolic therapy, GKI-adjusted ketogenic diet with or without calorie restriction, and fasting, aimed at increasing chronic metabolic pressure on cancer cells while favoring OXPHOS metabolism in normal tissues, as well as pharmacological ketogenic metabolic therapy, targeting of glycolysis and glutaminolysis in a press pulse design, in addition to cancer-associated pathways to normalize the tumor microenvironment. Figure 4. Prerequisites and potential experimental complexity of ketogenic metabolic therapy. Any interested patient can initiate dietary ketogenic metabolic therapy, ideally under the supervision of a trained dietitian. The resources and staff required for pharmacological ketogenic metabolic therapy are dependent on the number of interventions and clinical settings. Figure 5. Overview of potential drug treatments as part of ketogenic metabolic therapy research. Strategies are divided into glucose targeting, red, glutamine targeting, green, and tumor microenvironment stabilization, blue. Safe administration of metabolic inhibitors will require physiological adaptation to a GKI-adjusted ketogenic diet, with or without calorie restriction, which can be accelerated by water-only fasting. Then, glycolysis targeting can be considered to further improve GKI and slow tumor progression, e.g. antidiabetic agents such as metformin or SGLT2 inhibitors, as well as research phase glycolytic inhibitors. Glutaminolysis should be targeted at the same time, e.g. sodium phenylbutyrate, DON, or novel glutamine inhibitors. Finally, normalization of the tumor microenvironment can be explored in a modular fashion, for example, cell proliferation, mebendazole, inflammation, NSAIDs, hypoxia, HBOT, redox balance, DCA, intravenous vitamin C, immunotherapy, or combinatory approaches, e.g. CUSP9. Table 1. Key criteria for GKI-adjusted ketogenic diet implementation and troubleshooting. Implementation criteria. A GKI less than 2, ideally less than 1, with absolute glucose levels below 90 mg per deciliter, 5 millimolar. Troubleshooting. A knowledgeable dietitian should be available to assist patients in optimizing biological changes, e.g. maintaining deep ketosis, beyond ensuring diet compliance. Reduce total carbohydrate intake to less than 5% of total calories. Replace carbohydrate with fat sources. Review food tracking to detect hidden carbohydrate sources or ingredients that may impact glycemia, even if present in small amounts that only minimally change the food nutrition label. Pay attention to hidden carbohydrates in dietary supplements and excipients, as well as cephalic insulin secretagogues due to sweet taste stimulus, such as keto-friendly, zero-calorie sweeteners, e.g. xylitol, erythritol, allulose, stevia. If necessary and feasible, reduce total caloric intake, meaning a calorie-restricted ketogenic diet. E.g. reduce calories by 5% increments each week, until GKI goals are met. Implement intermittent fasting, e.g. 16/8 or 24, alternate day fasting, ADF, fasting mimicking diet, FMD, or prolonged water-only fasting. High-fiber ketogenic diets can hinder therapeutic GKI targets. Real-time monitoring via CGM, CKM, coupled with event logging can detect sources of variability, such as cortisol, sleep disturbances or pharmacological interference, e.g. corticosteroids. Medium-chain triglycerides, MCTs, are more ketogenic than long-chain fatty acids and can be incorporated into meals to increase ketosis. Ketone supplements can provide a temporary boost in ketonemia but are not a substitute for nutritional ketosis. Consider the impact of physical activity, stress management and circadian rhythms. To facilitate GKI targets, evaluate the suitability of gluconeogenesis and glycolysis targeting drugs. Implementation criteria. Preserve lean body mass, recover fat stores if gradually depleted. Weight loss, fat loss, during ketogenic metabolic therapy should be controlled and therapeutic, improving general and metabolic health. Troubleshooting. Optimize protein quality and quantity, especially during chronic calorie restriction or higher levels of physical activity. Protein intake in patients with cancer and normal kidney function is typically set above 1 gram per kilogram per day, and, if possible, over 1.5 grams per kilogram per day. Impact on GKI of higher protein targets should be monitored. It is important to account for the protein content in natural food sources. For instance, fattier cuts of meat tend to have slightly lower protein compared to lean cuts. Total fat intake will be variable to meet satiety and/or protocol caloric goals, e.g. caloric restriction. Cyclical caloric surplus, from fat and protein, not carbohydrates, while maintaining ketosis, can mitigate unintentional weight loss. Advanced disease-driving tumor host pro-catabolic effects and intensive treatment can aggravate pathological weight loss, muscle wasting, that must be differentiated from dietary ketogenic metabolic therapy. Implementation criteria. Adequate micronutrient intake. Avoid initial symptoms of keto adaptation, keto flu, and potential long-term side effects. Baseline assessment, blood panel analysis, and monitoring of health status. Troubleshooting. Metabolic adaptation can be facilitated by a gradual decrease in carbohydrate intake, e.g. change meal composition and frequency in stages, until all meals conform to ketogenic ratios. Ensure adequate protein intake, as long-term side effects can develop due to excessive protein restriction. Monitoring should be adjusted to the demands of standard of care and ketogenic metabolic therapy interventions. Table 2. Recommended and alternative methods for GKI-adjusted ketogenic diets implementation. Recommended methods. Instruct patients to measure blood glucose and beta-hydroxybutyrate at least twice daily, after the overnight fast, morning, and 1 to 2 hours prior to the last meal, evening. Real-time continuous glucose and ketone monitoring is the preferred method for data collection. Pre-specified GKI targets should be considered primary trial endpoints. Alternative methods. Measure GKI just once daily, ideally in the pre-prandial evening period, after the overnight fast, or prior to the first meal, if practicing intermittent fasting, maintaining consistency across measurements. Urinary ketones are not accurate for GKI calculation, but can inform sufficient carbohydrate restriction during diet initiation, in the first 2 weeks. Testing burden can be reduced after attaining diet stability, i.e. food selection remains unchanged, unless in a clinical trial. For long-term diet maintenance, glucose levels can be inversely correlated with ketosis. If carbohydrates are sufficiently restricted, maintaining a stable lower range of blood glucose, e.g. about 60 mg per deciliter, is likely accompanied by higher ketosis. Recommended methods. A ketogenic diet with or without calorie restriction should be assigned depending on initial weight and estimated fat mass. Patients can incorporate fasting in a cyclical manner, as dictated by their adipose tissue reserves. For example, patients with sufficient fat mass can implement a 3 to 7 day water-only fast, or a fasting mimicking diet, FMDs, every 1 to 2 months. Obese or overweight patients can extend fasting beyond 7 days under medical supervision. An average, temporary weight loss of about 3 kilograms can be expected after a 3-day fast, increasing to about 8 kilograms after 20 days. A significant fraction of this weight comprises glycogen-associated water storage and intestinal contents, which are quickly recovered. Under proper implementation, lean body mass reduction is minimal, and most fat mass is subsequently regained. Gradual adipose tissue recovery is feasible if the caloric density of a low-carbohydrate diet is sufficient. Fasting should not be limited or discouraged, unless there is a risk of cancer cachexia, but each fasting period should be planned and supervised. Inexpensive and non-invasive methods such as bioelectrical impedance can be used to track approximate changes in fat and lean body mass over time, within the same individual. Alternative methods. Underweight patients should not practice prolonged fasting without alternating cycles of weight recovery. Loss of lean body mass should be avoided. A trained dietitian should advise patients on implementing a small caloric surplus with resistance strength training to recover muscle and fat mass after fasting, or calorie-restricted ketogenic diet intervals, while still adhering to GKI targets. If body fat stores are too low, it may be preferable to avoid fasting and focus on GKI while maintaining an isocaloric diet. Ongoing changes in average weight, over several weeks, will dictate whether the diet is effectively calorically restricted, eucaloric or hypercaloric, regardless of self-reported or estimated caloric intake. Safety and contraindications of water-only fasting are discussed in reference 375. Special attention should be given to electrolyte balance and refeeding. If the patient presents with low fat mass, but normal weight, BMI, a fasting mimicking diet may be considered to avoid protein breakdown while potentiating therapeutic GKI ranges. Recommended methods. In treatment-naive GBM patients, dietary ketogenic metabolic therapy can be initiated as a neoadjuvant strategy with the aim of reducing tumor growth rates. In the absence of life-threatening symptoms, after surgery, select elements of standard of care that may be antagonistic could be preemptively scheduled, but delayed until completing a standalone ketogenic metabolic therapy period, including both dietary and pharmacological targeting, as defined in the treatment timeline, for a conservative maximum of 6 weeks. If sufficient radiologic responses or disease stability can be confirmed, radiotherapy and/or chemotherapy can be delayed again while intensifying ketogenic metabolic therapy, for no more than 6 weeks, and reevaluated periodically as long as regression or stability are maintained. During standard of care delay, it may be essential to perform sequential imaging to corroborate metabolic responses. Alternative methods. This, if, then, experimental design would be applicable to histologically and molecularly confirmed glioblastoma, before or after debulking surgery, given that delaying chemoradiotherapy for up to 6 weeks has shown little to no impact on progression-free survival and median overall survival, when no other treatment was given, representing a window of opportunity to institute ketogenic metabolic therapy. Outside clinical trials, patients are encouraged to discuss survival data regarding standard of care initiation with their treating physician. It should be noted that the long-term survival of glioblastoma with current standard of care is less than 10% at 5 years, independent of timing or dosing schedule. Follow-up with imaging and blood work should be provided to all patients, regardless of their desired treatment, preventing patient abandonment. Patients will be asked for informed consent after they receive education as to how dietary ketogenic metabolic therapy will be administered as a therapy, including how non-compliance could have a detrimental impact on the expected benefits. Follow-up should be frequent enough to detect early trends in tumor progression. Table 3. Recommended timeline for dietary and pharmacological ketogenic metabolic therapy research in glioblastoma. Key steps in the clinical implementation of ketogenic metabolic therapy. 1. Tumor diagnosis and shared decision-making. Overview. Brain tumor pathology is the gold standard for differential diagnosis. The preliminary diagnosis can be made via non-invasive techniques, as applicable, CT, MRI, PET. Liquid biopsy can be informative in extraneural tumors but has not been validated for glioblastoma. If maximal surgical resection is feasible, histopathologic and molecular characterization can be performed after surgical debulking. Initial tissue biopsy in tumors suitable for later subtotal or complete resection is more valuable when it provides actionable therapeutic guidance. Otherwise, final histopathological analysis can be obtained from surgical samples. Patients are encouraged to request detailed, written documentation regarding expected standard of care outcomes, long-term survival and quality of life, to facilitate informed consent. 2. Blood panel analysis. Evaluation of basal health status will determine the best therapeutic approaches, as well as feasibility of ketogenic metabolic therapy and chemoradiotherapy. It is advisable to formulate a well-defined schedule for tumor evaluation. In glioblastoma, radiologic imaging is necessary due to lack of reliable blood-based biomarkers. 3. Metabolic stratification. Glucose and glutamine are universally recognized as necessary for tumor growth, regardless of utilization pathway. In a research context, metabolite flux and substrate dependency of tumor samples can be assessed using in vitro, ex vivo benchtop, and in vivo metabolic imaging techniques. In the case of chemo-radiotherapy delay, clinical trials may require baseline and serial anatomic, metabolic imaging, e.g. every 3 to 6 weeks, to corroborate favorable responses. 4. Surgical debulking. The extent of surgical resection is one of the strongest prognostic factors in glioblastoma. If presenting with life-threatening symptoms, surgery should be performed as soon as possible, ideally with intraoperative fluorescence mapping, e.g. 5-ALA, or novel research phase metabolic markers. In the absence of such symptoms, a short watchful waiting period with dietary ketogenic metabolic therapy initiation, GKI-adjusted ketogenic diet, fasting, could be considered prior to debulking, potentially facilitating better surgical delineation. 5. Initiate dietary ketogenic metabolic therapy. Patients with good general health, as per clinical history, blood work and stratification of disease, and sufficient body fat mass may initiate ketogenic metabolic therapy with prolonged water-only fasting, longer than 3 to 5 days, which generally achieves a GKI below 2.0 during the fasting interval. Alternatively, it is possible to gradually transition to a GKI-adjusted ketogenic diet, which should be maintained as long as the tumor persists. Patients with sufficient body fat reserves may consider longer fasting periods, more than 1 to 3 weeks, which are safe under medical supervision and will provide longer cumulative exposure to reduced GKIs as well as autophagic effects. 6. Radiation therapy. For the clinical testing of combined dietary and pharmacological ketogenic metabolic therapy, given the conflicting metabolic consequences of brain-directed radiation, a request to modify the timing of radiotherapy may be proposed by the investigators. Late-stage adverse effects should be weighed against short-term anti-tumoral or synergistic benefits. For institutional review board approval, radiotherapy could be conditionally delayed or used at low-dose regimens until signs of disease progression. During informed consent, Patients should inquire about the absolute survival increase provided by radiotherapy, along with the possible short and long-term side effects. 7. Drug treatments. Ideally, all drug treatments, especially metabolic inhibitors and chemotherapy, should be administered in a GKI less than 2 range. After achieving a therapeutic GKI-adjusted baseline, glycolysis and glutaminolysis should be targeted simultaneously. Various diet drug combinations can be evaluated to this effect, e.g. targeting insulin signaling via repurposed drugs such as metformin or SGLT2 inhibitors, or direct metabolic inhibition using research-phase glucose and glutamine antagonists. Further stabilization of the tumor microenvironment or targeting of cancer-associated pathways, including immune-based therapies, can be initiated after the effective restriction of fermentation metabolism while increasing whole-body adaptation to nutritional ketosis. 8. Physical activity. An individualized dose of physical activity that promotes long-term muscle maintenance and aerobic fitness is recommended. The type of exercise should be based on the patient's training experience and current exercise capacity. Resistance training preserves muscle mass, increasing a major physiological glucose sink, further enhancing ketogenesis through decreased insulin secretion. 9. Stress management. Given that active participation and motivation is required for successful ketogenic metabolic therapy implementation, patients should receive adequate psychological and emotional support to enhance quality of life, reduce non-compliance, and avoid stress-related therapy excursions. 10. Evaluation of outcomes and therapy adjustments. Radiologic imaging should be performed within 2 to 8 weeks of ketogenic metabolic therapy initiation. Current guidelines recommend brain imaging every 2 to 4 months during the first 3 years from diagnosis. Treatment can be adjusted in the event of tumor progression. Repeated surgical debulking can be planned for slow-growing tumors. This video was produced for www.school.com/keto for cancer.